Welcome to the McGregor Dementia Support Ministry podcast, offering clarity, guidance, and encouragement for families navigating dementia. Today's episode is one of our breakout sessions from the February 21st, 2026 Alzheimer's and Dementia Seminar at McGregor Baptist Church. In It Dementia, Dr. Benjamin Mast helps families think carefully about when cognitive changes move beyond normal aging and require further evaluation. He addresses important questions such as, when should you ask for an evaluation? Which symptoms shouldn't be ignored? How do you begin what often can be a very difficult conversation? Who should be involved as you build a care team? And what does the screening process actually look like? Well, if you've been wondering whether it's time to take the next step, this session provides thoughtful and practical direction.
Welcome, everybody. You may remember me from up front earlier. I'm Dr. Mast. So this breakout is designed to help you navigate the question that you have in front of you. Is it dementia or something related to it? This is meant to be interactive, but only in the sense that I'm going to talk for the first half-ish of our time, 45 minutes, and then I want to hear your questions, okay? There are some things I want to cover just to structure our time a little bit, because I think sometimes these will answer some of the questions, but I'll stay on target with time. Just by way of context, so they talked a little bit about what I do earlier. So I'm a professor, but I also work in a multidisciplinary geriatric clinic where people are getting their first diagnosis, and I do the testing that helps either confirm or help the docs understand whether the memory is normal or other cognitive abilities are normal. So this is what I do fairly often, and so I'm talking about it from that context, right? So you might be wondering, so let me just jump in. So this is what we're gonna try to cover today: when to ask for an evaluation, how to get one, how to get screened, what else might be involved in the evaluation other than screening, who should be involved, and then at the end I want to talk about anxiety, fear, and memory changes. Whether you're consider yourself an older person, whether you're middle-aged, these are relevant questions. There's a lot of middle-aged people walking around wondering about their own memory, and so I want to talk a little bit about that as well. So some of the terms, I think Dr. Shaw covered this fairly well, but as we go back into it, we might want to revisit some of these things, right? I'll try not to stand in your way the whole time, but I don't have a little remote this time. So when we're doing an evaluation for possible dementia or another cognitive disorder, we're often making distinctions between normal cognitive aging. So as we get older, memory changes, thinking speed changes. It starts typically in middle age. Everybody experiences it. It's a matter of degree. How much change? And is this normal amount of change or not? Well, I'm going to skip this for now. Mild cognitive impairment is that sort of in between normal aging and dementia. From an evaluation perspective, a person gets the diagnosis of mild cognitive impairment when they have shown that their memory or cognitive skills are lower than you would expect for normal aging, but they're still relatively independent in everyday life. That's what we mean by MCI, right? And that captures a lot of different scenarios. As Dr. Shaw said, some people with MCI go on to develop dementia and some people don't. Some people stay stable with MCI for years. From there, we talk about mild dementia, and the difference between mild dementia and MCI is when people are starting to lose that independence. They can't take care of their business like they used to, whether that's money, medications, driving, taking care of the home. You know, Dr. Shaw mentioned computers, technology use. I think that one's a little bit tricky. But once you start to see those things declining, that's when we're moving more into dementia, right? So as we think about how you do the evaluation, some of it's going to be testing of memory, but another part of it is understanding from people who see the person every day, how independent are they? Because many people will tell me when I'm testing their memory that they do everything on their own and they're fully independent. And then when I talk to their family, they say, no, that was years ago, right? They're not. And whether that is defensiveness, denial, or they don't understand how much is being done for them. So if you are a family member thinking about how do I get somebody evaluated, right? Just know that the things that you say about their everyday life are going to be very important in making a distinction between mild cognitive impairment and these different dementias, okay? Moderate dementia and beyond, we're probably not covering that territory in this particular breakout, but sometimes people think they're getting an early evaluation and it turns out they're already into moderate stages of dementia. That happens quite often, right? So these are some of the terms. Subjective cognitive decline is that's when people notice something is different about their memory or their thinking, and sometimes it doesn't show up on testing, right? They just notice something. It's like, I notice something is different in myself, other people don't notice it, it doesn't show up on screening. So that's another category. It's not a formal diagnosis, it's a way of recognizing, yes, you may have noticed something is different, it doesn't show up on testing, you don't meet criteria for a diagnosis of MCI or dementia. We're going to continue to monitor it, and maybe we'll work on things that might help you remember better. Okay? So when to ask for an evaluation. I have multiple slides on this from sort of, I wouldn't say red flags, maybe orange-ish flags where you want to think about getting somebody in, and then we also have symptoms to not ignore. Anytime somebody who, whether it is you, but most often somebody you're caring for, experiences a sudden, abrupt change in their memory, or confusion or time orientation, just sort of knowing, what day it is, what year it is, what month it is, that's a time to get them to the doctor, okay, or nurse practitioner, healthcare provider. And it doesn't have to be a neurologist, it doesn't have to be a specialist, but dementia, MCI, Alzheimer's, Lewy body dementia, frontotemporal dementia, vascular dementia, all of these things do not come on suddenly. So what I'm saying here is when you have what we call a mental status change, one day they're doing pretty well, a few days later they're incredibly confused, that's a right away, because it could be something serious. It could also be something like a urinary tract infection, which is not to say that's not serious, but it's something that's much more treatable than Alzheimer's disease. So it might not be dementia, but you definitely ought to get them in because there's no reason to wait. Other indicators, clear change from prior levels of functioning, that's a little bit gray area, but you notice this is really quite different if I think back to how they were doing a year or two ago. Ability to do everyday activities. These are the things that Dr. Shaw was talking about, instrumental activities of daily living. It's getting worse over time, not better. That's another time to ask for an evaluation. And any of this combined with a family history just kind of pushes a little more pressure on getting the evaluation. Now, if you're like many people, you hear that and you think, well, I have a family history. Does that mean I need to get an evaluation? That's not what I mean. A lot of people have a family history and don't go on to have any dementia. But when you're combining memory concerns with a family history, it's a good push to go ahead and get it checked out. We're going to talk about what that means. There are things that you can do that are relatively simple. And sometimes if you're just worried about it, you should just go ahead and start that process, and I'll explain what that is. Because sometimes you actually get good news, right? This isn't dementia. We just need to understand what is going on. It isn't always dementia, and that's kind of the point. Because if it was always dementia, then people would say, well, maybe the treatments aren't as good as we would like. Maybe you heard the things that Dr. Shaw said, well, why do we want to get it diagnosed? And there is good reason to do that. But one of them is it's not always dementia. It could be something else. So symptoms you shouldn't ignore. This is coming, again, by way of context from a person who does evaluations. And in my view, there are not as many risks for starting an evaluation process. You might look at that very differently, right? Maybe you think that's easy for you to say you're the one giving the tests, and I agree. It's a lot easier for me than it is for you. Consistent forgetting of recent conversations, right? Forgetting one conversation, okay, maybe you were distracted, maybe you weren't listening, but if it's happening over and over, that's a time to start thinking about we need to talk to somebody. Forgetting appointments and family events. Notice I said consistently. So Dr. Shaw talked about normal aging versus dementia, and sometimes there's a lot of overlap, and you think, well, walking from one room to the next and forgetting why you came in there, that is normal, right? It is. It's the number one. So when I ask people why they're here for the evaluation, they say, my memory is bad. I was like, what does that look like for you? Which is a tricky question because you're asking people to remember what they forget. But most of the time people say, it's bad. I walk into one room and I can't remember why I got there, right? That's not it. But what you're talking about with any of these, like forgetting conversations, appointments, everybody forgets some appointments, but you're talking about it happening over and over despite ways of trying to compensate for it, right? So if you miss a doctor's appointment because you didn't put it in your calendar, it's fine for you. It's not fine for the office, right? But if you are then writing it down and you're still forgetting, okay, then start to think about an evaluation. Getting medicines mixed up, I would say, again, consistently. For me, these are things where if people are saying, should I get an evaluation or should I not? These are things that make me say, why don't you go ahead and just start the conversation with your doctor? And that is the starting point, usually. Falling prey to scams, Dr. Shaw talked about that as well. There's now good research evidence that suggests that for some people, financial exploitation, scams, having difficulty managing their checkbook, money, is something that shows up reliably. Sometimes people need a big event to make them understand that it could be dementia. I learned about Alzheimer's the first time in college when my grandfather, who couldn't hear very well, didn't pay attention when we talked to him despite asking the same questions over and over, went to his plumber's union meeting in Denver, Colorado, and ended up at a farmhouse in Kansas, right? That was the big event. Sometimes for people, it's getting scammed. They get scammed, people start to take a closer look and they think, oh, actually quite forgetful, maybe there's something else going on. It doesn't mean if you got scammed, you have dementia. I'm not saying that. I really want to be clear because lots of people get scammed, right? Scammers are quite good at it, at least most of them. Problems managing money, loss of interest in usual activities. Person was very involved and they just start to drop them. This is one of the key symptoms of depression, especially depression in later life. Again, Dr. Shaw talked a little bit about this, that new onset depression in late life is relatively rare. That doesn't mean, some people have depression on and off their whole life, but that can be an early sign of something else going on. I'm moving over here, so step out of your way. Getting lost, disorientation, time and place, irritability, outbursts, especially in people who did not have that personality before. So if they've been kind of easy to get along with and now they're irritable and angry all the time, doesn't mean they have dementia, does mean this would be a good time to start an evaluation. None of these mean you have dementia, just to be clear. Difficulty with speech, saying words, articulating, difficulty understanding what people say. Social withdrawal in a previously social person, so a change. Paranoia, new paranoia. So what I'm talking about here is people are stealing from me when there's no real good evidence that they are. There are people in the house that other people don't see. That's more a hallucination. Again, it doesn't mean it's dementia, but it is something that kind of borders with the dementia and other significant problems. Seeing things, sadness, talking about death, no longer taking care of the home. Again, when it's a change, right? Some people don't take care of their home for various reasons. So when these are a change, they're all things that would encourage me to say, you should start a conversation, okay? Finally, if you worry, right? If you worry about dementia, you should think about starting that conversation, getting an evaluation, okay? There are people who my age-ish and beyond, sort of 50s and beyond, who live in fear of dementia because what they saw in their family member or their parent or an uncle. And those people can really benefit from early contact with a healthcare provider to provide appropriate information and guidelines, because it's really hard to monitor your own memory change, especially when you're anxious and fearful, right? It's just true. If somebody that you trust, family member or friend, asks you to get an evaluation, you should do it. Because oftentimes the people who know us well see things before we do, or at least at some stage in this progression. And you can talk about it at your annual wellness visit. Okay, let's keep moving through. How to get an evaluation. I'm assuming, but this might be a bad assumption, that many of you came here because you want to understand how to get an evaluation on somebody that you care about, who is reluctant to do so. You might be here because you're wondering whether you should get an evaluation, right? So I think my message to you who are looking for an evaluation for yourself is going to be really easy to understand. And hopefully the things that I say will give you an answer. If you're in the other camp and you're trying to get somebody an evaluation who won't go or doesn't believe they have a problem, this kind of is for you, all right? So the first step is to talk to your primary care provider, physician, nurse practitioner, okay? And the point is to get the person into the office and have them discuss memory issues, all right? Now, I know this is complicated. It's not so straightforward to just say, okay, dad or wife, I want you to go in and tell them about your memory. And then you go to the appointment and then the doctor says, how's your memory? And says, this is great, and it's fine, and there's no problem. And then they interact with the provider in a way that seems totally appropriate. They put on their best face, and you thought, what did I just have that big argument for, right? That's very common. It is, if I could just put in one pitch, that is the advantage of going to a geriatrician. So I work with geriatricians. So are physicians who specialize in aging and aging issues. They are much less likely than a general practitioner to fall for my memory is totally fine. And this is where having screening really makes a difference. Okay, screening helps you understand, put together that statement, everything is fine, and how they did on the screening. Okay, I'm already failing on my half I talk, half you ask question, but I'll get through it. If you're worried about that, here is one thing you can do. It's a little risky, but it works, is to write a letter. If you are very convinced that the person that you care about is having significant memory problems and you are not allowed into the room for one reason or another, we receive letters from families that say, I know I'm not going to be in the room because my mom doesn't want me there, and I'm reluctant to even bring this up, but I am concerned about her memory, and here are a few examples of things that I've seen. Keep in mind dignity and respect, but in my view, if that is a real issue, if that is a real memory issue that you're trying to get addressed, that is showing them dignity and respect. Because what's really hard for people is when they want to argue they don't have memory problems and you're in front of them having the conversation with the doctor and you are 1, 2, 3, 4, 5. These are all the things I've seen them do, which you might have to do that. You're trying to get help. But sometimes a letter can be really helpful, okay? It's risky because it feels like you're breaking trust. But if the person really is developing dementia, you're going to need to get used to that you're going to need to do things at some point that they might not think are the most appropriate steps. And one of the reasons for that is you can see things a little bit more clearly than they can. It's very hard. I don't want to make it like it's easy. Bring questions. If you're talking to them about trying to get in, brain health checkup is much more friendly than a dementia evaluation or even memory testing. Okay, they are the same thing, but sometimes the language makes a difference. Okay, let's keep moving through, and we'll do questions. So how can you get screening? Screening is really important, and it's kind of the first step. So you can talk to your primary care provider, ask for screening. Your annual wellness visit, which is paid for by Medicare, they will do screening. Some of you have already had it done. You know the deal, what it looks like. What they're going to ask you to do. We could probably go around the room and put together what the screening test looks like just based on your experience. You can sign up to get screened here today. Not screened today, but sign up today, and they're doing them here at the church. So the reason why I think that this is a good step, and I don't do screening. I'm the person that you see after the screening has been done, okay? And so I'm not saying this to say you should refer for my services. We're in a totally different state. But this is, it's a quick estimate of what their cognitive functioning looks like. It's one piece of data that says, is this normal aging or could this be some form of cognitive impairment, whether it's MCI or dementia? It's designed to help them determine next steps. It's not diagnostic. They should not make a diagnosis of dementia based on a screening test. It's just information. It's like triaging, right? So screening tests, they might ask you, to remember some things, draw some things, repeat some things back. Quick and dirty, 10, 15 minutes max. It's like taking your blood pressure, listening to your heart, listening to your lungs, but this is for your brain, okay? I strongly recommend it. As if you're concerned, just try to get people screened, all right? Now, we can talk at the end, what happens if you're convinced they have memory problems and they do fine on the screening? And I will explain why I think that happens. What else might happen? So this is kind of current standard of care diagnostic workup for dementia. History and physical. So you've got to get them into your primary care. Cognitive screening, they'll draw some blood, they'll take some urine, rule out things like urinary tract infection, deficiencies in terms of nutrition. Brain imaging, so this is not usual, this is a CT or an MRI, not the PET scans or the amyloid imaging that Dr. Shaw was talking about, but this is to rule out tumors, hydrocephalus, stroke, old brain trauma. Then they might refer them for neuropsych testing. So that's what I do. This is a multiple hour evaluation, and it is really helpful in understanding what diagnosis people might have that's most appropriate. For those who are anxious about memory changes, sometimes this can be a really encouraging experience because they find out, 477 or 483, this is actually pretty typical performance, and that's helpful for people, right? Because as you're getting older, you'll feel more forgetful, and sometimes it's helpful to have that feedback. Say, I know you feel more forgetful, but on this test, you're remembering X% more than the average person your age. That's really nice to know. Doesn't always work out that way, but it can.
I'm just taking a picture. I'm sorry.
Yep. They may do biomarkers. This was referred to earlier, amyloid imaging. Dr. Shaw talked about that. It shows the plaques for Alzheimer's. It's currently growing to be the gold standard for Alzheimer's diagnosis. If you don't have the plaques, you don't have Alzheimer's disease, you have something else. Cerebrospinal fluid, same thing. You're looking at those amyloid and tau proteins to determine whether the cognitive change is due to Alzheimer's or something else. Same with the blood test. He talked about p-tau 217. Skin biopsy, that's for Lewy body dementia. They do a little skin biopsy. It shows the proteins associated with that form. You may not get all this, right? You don't need all this first. You've just got to get in, start the conversation, get some screening, and work with the provider from there. Most of the time, those biomarkers I was talking about are used in these earlier stages, MCI, early dementia. If you're caring for somebody who's in the moderate stage or beyond, if you're doing a lot of hands-on care for them, the biomarkers are not what you need. Don't worry about the blood tests, about the PET scans. They're early. Okay, who's going to be involved? I think that's kind of obvious so far, but you, if you're the patient, and somebody that you trust. So Kim talked about starting to build your team. You need somebody who is a personal friend or family member who you trust. Sadly, you can't trust all friends or family members, so you need somebody you can trust. Some financial exploitation happens in families, so you do want to bring somebody trustworthy. Physician or nurse practitioner, medical specialties. Point number 4 here is very important. You do not need to wait on the neurologist to start this. This is no shade on neurologists. It's just it's a very long time to get in to see a neurologist. And if you're really concerned about memory, you can start with other specialties. And if they feel like a neurologist is needed, they'll get you in. But don't wait. Don't wait. If I had to pick, I would pick a geriatrician. That would be the starting point for me. They take more time. They are welcoming of having family in the appointment. They'll ask you your opinion. They'll listen to you. I mean, maybe this is too optimistic on my part. That's been my experience. Okay? You might see a psychologist, somebody like me. Social work might be involved. There are now Medicare-approved dementia-related services, things like respite. Social workers will help coordinate those. That's a little bit down the road. We're almost to questions time. Jeez, time goes so fast. What else could it be? It's not always dementia, other medical conditions. We talked about tumors, talked about thyroid issues earlier today, vitamin B12 deficiency, delirium, that's that rapid onset confusion. Could be what we call polypharmacy, too many medications on aging brain and kidneys. Depression, anxiety will present as memory problems in late life. Other mental health conditions, you can look at the list. Any of these can cause memory problems in middle-aged and beyond. So I encourage you to think about those. If you're middle-aged and you're worried about your memory, I think getting screening makes sense. It doesn't mean I think you have memory problems, but sometimes you need that data point that says, actually, right now it's okay. I know that might not be the most encouraging answer you could receive, but if you or you've known somebody who is in that situation and they worry all the time about their memory, there's got to be something that breaks that cycle, because worrying about your memory is one of the worst things you can do for your memory in reality. All right. Let me just say 2 quick things, and then I'm going to wrap up so we can do questions. Prevention has been touched on a number of times today. If you are middle-aged or even later in life and you're worried about this, please consider these things. This is not the same as it used to be. 45% of cases are estimated to be preventable through lifestyle factors. That is not, that's not the untrustworthy story Cynthia is talking about. This is published in a major worldwide respected medical journal, that if you manage lifestyle factors, there's a 45% of cases could be prevented. So physical exercise, social activities, vascular risk factors, this is your blood pressure, your sugars, your cholesterol, heart conditions. If you have them, follow your doctor's recommendations. The Mind Diet, look it up. It's part of that same Pointer study that Cynthia referred to. Get your hearing and vision checked, okay? Don't know why exactly, but unchecked hearing loss and unchecked vision loss are associated with higher risk for cognitive decline. So easier said than done. I know I need to get my hearing fixed. Got my eyes done this year. Hearing is next. Cognitive activity. I just want to point this out. I never recommend apps or games, but I'm going to recommend this one. So this came out this week. It's called a speed of processing training. It's you basically look at the screen, it presents you a car and a Route 66. You've got to pay attention to it and then pick out where it was. Maybe you saw this. But this comes from a clinical trial that started in the 1990s. They've been following people out for 20 years. So it's Brain HQ is the name of the company. It's speed of processing training. They showed a 20% reduction in dementia over a 20-year span for people who had the training. It's actually kind of fun. I did it the other day, and it was a little harder than I thought. So that's the only technology thing I'm going to recommend today. But
I'm sorry, what is the name of it?
the company is called Brain HQ. And it's a speed of processing training. Or Google NBC cognitive training dementia. It came out last week. And you can, in the NBC story, you can try it. They've got a sample in there, and then you can decide whether you want to pay, I think it's like $10 a month to do it.
Doctor, there was something back in the page before that.
Yes, sir.
I want to ask you about what the idea of mind diet was. Is that
So it's like the Mediterranean diet. So you're thinking, for better or worse, less red meat, less fatty foods, a lot of green leafy vegetables.
Oh, it's not about the types of material that you read?
No. Oh, no, it's actually a physical diet, what you should eat and drink, yes. Sorry.
It was something to do with the type of material.
Nope. No, but you should have cognitive activity. So yes, okay. I want to go to questions because that's what you came here for, and we can talk about the preparation stuff if you'd like. Okay. Yes.
Okay, so for talking about PCPs, geriatricians,
Yes.
and then just screenings.
Yes.
For someone who doesn't want to go in the first place.
Right.
Who hasn't had a PCP in a long time.
Yes.
What is I know you suggested different things, but
Yep.
we've got one chance to get in the door, so what would be the best?
Repeat the question.
I will repeat the question. We're recording anyway. So basically, if you have somebody who hasn't been to a physician in a long time, you got one shot, how do you get them in the door, right? Okay, I want to reframe it a little bit. It's not one shot, right? So I think sometimes we think if we have to figure out the right thing to say, kind of like when somebody, back in the day, when somebody was an alcoholic, you're like, I'm going to have an intervention. We're all going to line up. We're on our same page, and we're going to confront them with it to get them to see that they have a problem. And I know that's not what you're saying. But sometimes when we're trying to convince somebody on a memory, we think, I've got one shot. I got to say the right words. And I would encourage you to think about it as kickstarting conversations with them and say, it's like, Dad, you haven't been to the doctor in a long time. A lot changes as we get older. Let's just go have a check-in or something like that. No, I don't want to do that, right? In boxing, I'm not a boxer, they call it stick and move, right? So you took your one shot, you missed, or they were defensive, back off, circle around another day, try it a different way. I think when we think it's got to be a one-shot thing, it makes it like we've got to say the right words. And I think you want to draw on, you're not as young as you used to be. I want you to be as healthy as possible. Could you at least just go get an annual checkup?
Your response is fear of testing.
Yeah.
So
Okay.
she may well know she already has a problem.
Yeah.
And just doesn't want to discuss it.
Yeah.
Or she's talking about testing, like, if I go have an annual checkup, I'm going to have to do a colonoscopy, or I'm going to have to do
Yeah.
this and do that.
Yeah.
I'm not sure which one she's referring to.
Yeah, so the question was, what about fear of testing? And sounds like not just mental testing, but colonoscopy. I do think you need to appeal to them, try different methods, and just keep at it. but just kind of take the pressure off. You got one shot. There was a hand in the back. Yeah.
So having a screening is not a formal diagnosis.
Correct.
And
Yes.
my impression is that some insurances require formal diagnosis in order to provide extra care, like in-home care, stuff like that.
Okay.
And that formal diagnosis is only going to come from going to like a neurologist, correct?
Not necessarily. So let me make it sound like I'm talking out of both sides of my mouth at once, okay? A screening should not be used as a diagnosis, period. Now, somebody is experiencing significant cognitive change, right? It's obvious to everyone, maybe it's been going on for some time, and you're trying to qualify for services, right? So there's a new Medicare program called GUIDE, where they can provide in-home respite funded by Medicare, right? You need a dementia diagnosis to get it. Would a geriatrician take a history of multiple years of memory decline plus a cognitive screening test and their usual evaluation to make a diagnosis so you could get services? Absolutely. They'll do it all the time. And that's different, though, than a person showing up for the first time, maybe just starting to have memory problems, complaining about it, and does poorly on the screener, right, without a lot of background concern. That shouldn't be a dementia diagnosis. Does that distinction make sense? Okay. Next question. Yeah.
How close is dementia to Parkinson's?
So they're different. So I would say it like this. Parkinson's is a neurologic condition. It can affect cognition, but not everybody with Parkinson's gets dementia. Okay, so people with Parkinson's will have, some slowing, especially physically, cognitively. But the percent of people with Parkinson's who go on to develop dementia is somewhere between a third and half, I think, if I'm remembering correctly. So they're different, right? They both affect the brain. But the changes, the tiny changes happening in the brain of the person with Parkinson's are happening more in the movement and balance centers. And if it spreads to the more cognitive areas, that's when you start to see the cognitive changes. There's a related condition called dementia with Lewy bodies. Yes. Now, Lewy bodies and Parkinson's pathology are the same abnormal changes, but they're happening in different areas. In Lewy bodies, they're happening more in this doesn't make sense. They're all happening in the brain, but they're happening in the cognitive areas, right, and then spreading to the motor areas. And it's sort of like Parkinson's in a reverse progression. So the Lewy body is a specific abnormality, and where it happens will determine whether it's Parkinson's or Lewy body dementia. But when somebody has Parkinson's dementia, it means they had Parkinson's disease for a while without cognitive decline, and then they experienced a notable progression into cognitive impairment and loss of functional independence. Other questions? Yes?
Somebody may have asked this before, but is this, people typically not want to be tested if you've got it? Some people really want to get tested. They are eager for it because they're worried, or they are of the personality type that is very proactive and they think, I want to do everything I can. It has changed over time. So as we recognize these cognitive disorders earlier, I see more people who are requesting it for themselves. It used to be 20 years ago, people were getting dragged in and they were already pretty progressed. So it goes both ways. Some people are terrified, don't want to do it. Other people couldn't get there soon enough, in their view. Yeah?
Yeah. What about connections between mental illness
Yes.
and dementia?
Yeah, so mental illness is a very broad category. There is some association with things like midlife depression and higher risk of dementia. But usually when people are asking the question, it is, what is it? How do you know when a person who has a long chronic mental illness develops dementia, right? Because sometimes they've already shown cognitive problems, disorientation, maybe not good at organization, forgetfulness, and that's trickier.
And what the providers or the psychologist is usually looking at is noticeable change from prior levels of functioning. So it's both things, right? So things like depression increase your risk, not a ton, right? So it's nothing to, if you're already depressed, don't worry more about this, just get your depression treated. But you also do see some overlap because people from all walks of life with all sorts of problems develop dementia, kind of like Cynthia was talking about. Where's another one back? Yeah.
All right, so my mother recently, part of an admission process into an assisted living, went through an evaluation where you draw the clock and
Yes.
the questions you remember, the sequence, all that kind of stuff.
Right.
She did very well.
Yes.
So I was sitting there with her.
Yes.
But she has some very clear delusional thinking.
Yes.
That has to do with suspiciousness and those kinds of things that she believes
Yes.
entirely. Is there an evaluation for that, and how do you,
Yes.
how can another person reality check? I know because I know the facts.
Yeah.
My father, I know he doesn't have the means, motive, or opportunity to do things she's convinced
Yes.
are happening.
Okay, so let me repeat that really quickly. I'm very glad you asked. So situation is mom's admitted into assisted living. Part of that, they did a clock drawing task, which is one of the simple screeners. She did fine. So, no red flags raised, but in her behavior, there's issues, maybe some paranoia, some delusions. So what's up with that and what happens? So this happens a fair amount, and a screening tool is just a tool, and it happens to be a good first step. But it doesn't mean, just because you scored well on the test doesn't necessarily mean there's no cognitive problems, right? So what I would recommend is when there is a clear concern from family, things that you can see, this is clearly unusual, that you persist in talking with them and saying, I know that you did well, but I'm seeing these things. Can we get more evaluation? Maybe it would be a neuropsychology evaluation like I do. Maybe it would be a geriatrician. Can I give you a quick analogy? I know we're almost out of time, but I had cataract surgery this year. And afterwards, they're like, how did it go? They want to know, right? And I'm out in the world not being able to see highway signs, coming down the road, right? So in the world, I'm having trouble with my vision, but when they do the little scorecard, I read 20/20, right? So think about that in terms of what is the task here? The task is in ideal lighting situations, good contrast between the type and the background. It's not moving, there's no distraction. I can read 20/20. But when I go out on the highway and I've got, maybe somebody else talking to me, there's light, my windshield isn't very clean. I actually took this while driving. I took some risks for you all. But this sign is very blurry for me, and I can't read it until I'm too close, right? So the very best way they can evaluate my vision in office is through that card, right? Those types of things. But seeing in the world is more complicated than seeing an eye chart. Remembering in the world is more complicated than drawing a clock and remembering 3 words afterwards. So even though I recommend you get the screening, you have to recognize that at some point, they don't match the challenges that the person in their everyday life might experience. So I think if you want to address that, I think that's kind of the point you want to push is, I know she did okay, but we need some more evaluation because the things she's saying are not like her, and there's no evidence to support them. Can we please get more evaluation?
So how many years has that particular screening test been in use? Forever now, right?
Well, yeah, right. Well, so there's different tests, and different people use different ones, but they're all iterations of the same thing. Yes. But they do revise, and they will come up with new ones. But the point is to say, think about this just as a step in the journey. Okay? All right, I ran out of time. We're going to the Q&A.
Thank you for joining us for this helpful conversation. If this episode clarified next steps or encouraged you to seek guidance, please subscribe and share it with someone who may need it.